Welcome, everybody. I'm Melissa Arbuckle, the Vice Chair for Education, and it's really my pleasure to welcome you to the new year and to our Grand Round series. I have a couple of announcements before we get started. It's really my pleasure to announce two faculty awards. Two members of the Columbia Psychiatry faculty will be receiving the Irma Bland Award for Excellence in Teaching Residents from the APA at the annual meeting in May. From our salaried faculty, Dr. David Lowenthal, Associate Professor of Psychiatry here and Clinical Director of the New York State Psychiatric Institute, will be receiving this award. He's a longtime faculty member and a longtime mentor. From our voluntary faculty, the recipient is Dr. Eugene Freeberg, who was a chief resident here in the 1960s and has been on the psychoanalytic faculty and has been supervising residents ever since. In fact, he was one of my supervisors, so I'm really pleased to see him receive this award. I'm also excited to announce a resident award. Dr. Mimi Levine, one of our third-year residents, has been accepted by the American Association for Geriatric Psychiatry into the prestigious 2017 Geriatric Mental Health Foundation Honors Scholar Program. And with this award, she'll receive a travel stipend to attend the annual AAGP meeting in March in Dallas, Texas. So congratulations to all of them. For next week's Grand Rounds, we're going to have one of our own chief residents, Patrice Malone, will be giving a clinical Grand Round, so we look forward to our clinical staff joining us for that. And now, because we have a special named Grand Rounds, I'm pleased to introduce Mara Wren, who will talk more about it.
So again, I'd like to join Melissa's welcoming everyone, and as well as wishing everyone a very happy new year. And it's a real special honor that we're launching our 2017 year of Grand Rounds with this special named Viola Double Bernard Grand Rounds today. I just wanted to give a little background about the foundation. The Viola Double Bernard Foundation gave this past year in 2016 a $1.1 million gift to support the programs in the Department of Psychiatry, Division of Child and Adolescent Psychiatry. This gift represents a significant expansion of our already established endowed program that we had that started in 1982. This involves providing very important permanent support in this gift will advance the efforts in research, training for child psychiatry fellows and faculty and clinical services with an emphasis on the needs of children who are underserved and at high risk. The fund honors and extends the legacy of Dr. Viola W. Bernard, who was a longtime PNS psychiatry faculty member who died in 1998. Dr. Bernard, who was associated with Columbia for more than 5 decades, dedicated her career in psychiatry to understanding and helping adopted and foster children. She was an authority on community and social psychiatry, child psychiatry, and adoption, and she played an important role in the evolution of our division here of child psychiatry and our care for these children. We are very fortunate that we have this endowment to support special initiatives that will be dedicated in the advancement of caring for children in our community, and certainly those children that are higher risk for mental health issues. The other thing I need to also mention, we had another small endowment by the Viola family, which was sort of interesting, Vincent Viola's family, and it's also the Viola Bernard Endowment. So this other family, actually, we had a small endowment contribute to the Viola Bernard Endowment in order for us to really enlarge this mission. So I'm enormously grateful to that family as well for joining forces with the Viola Bernard Foundation. We also have distinguished guests here today, and one in particular that I would like to thank is Mr. Eric Breckschneider, who's the Deputy Director of ACS, who also chaired the Viola W. Foundation Board and was a part of this process of expanding the endowment. So we're enormously grateful that we have this support in Child Psychiatry Division that will expand the mission in this area, both for training and research in this area, and again, to have this yearly Grand Rounds to be supported. Along with the Grand Rounds, there's also an extensive training program that's a part of this, which Dr. Erica Chin will talk about. I also would like to thank Dr. Erica Chin, who is our Associate Director of Clinical Services for our ambulatory services for the department, who has gracefully accepted directing this endowment to make sure that we're following the mission very careful. We really wanted someone that's going to really steward this well, and she's been doing a fabulous job with that. And so I thank her, and I asked her to join us on the stage because she's going to introduce our distinguished guest today, and as well as also talk about the training program. Thank you.
Thanks, Moira. So again, we are just completely thankful and very grateful for the Viola Bernard Endowment, mainly to continue to support training, development, and real support to our clinical faculty. We just recently had a meeting, and one thing I take away is that our greatest resource is really you. It is our clinical staff, the people who dedicate their profession, their craft, and their lives to caring for children and families. Particularly up here in Washington Heights, for all of us who serve, one of the other continued impacts is being able to partner, to draw close, and to really put ourselves in communities where those who are underserved, those who are most vulnerable, and those who are most in need, that we're willing to go into those communities and actually serve and bring the highest quality, the best science, and the most compassionate care to those populations. With this spirit, sharing, I think, the mission of what Viola Bernard really embodied was to be thoughtful to the families who struggle in these ways and to really walk with them in their stories to make sure that they get care that actually improves their lives, that we really engage them in ways that are compassionate and validating, that we are equipping them with skills and the kind of care that will help their lives improve, and to empower in the community to really actually stand up and serve together. To those means, the Viola Bernard Institute has provided both training. Last year, we had parent-child interaction therapy, as well as we're going to move and do IPTA with Laura Musson this year. And of course, we're going to have our great speaker today, Elissa Brown, talking a little bit more about our dedication to caring about children and families affected by trauma. These training efforts have not only been our workshops, but have actually extended throughout the year. So our staff and faculty in the division have also participated in year-long supervisions, consultations. We've also built community partners, both at Metropolitan, also at Joe Torre Safe Homes, as well as our other community partners and CBOs, to really enhance and grow a community that wants to continue to learn and equip training and development of effective treatments for children and families. With that, I'd like to introduce Elissa Brown. Dr. Elissa Brown is the founder and executive director of the Child Help Partnership, and she is a professor of psychology at St. John's University. She received her BA in psychology from the University of Pennsylvania and a PhD in clinical psychology from SUNY Albany. Her primary clinical research interests include the prevention and treatment of child trauma and post-traumatic stress disorder. She has participated in research on the assessment and treatment of sexual assault, child physical abuse, and bereavement related to traumatic circumstances such as September 11th. Her work at the Child Help Partnership has been supported by the National Institute of Mental Health, New York State Office of Mental Health, Substance Abuse Mental Health Services Administration, Department of Justice, and private and corporate foundations. Dr. Brown is also a co-developer of Alternatives for Family, a cognitive behavioral therapy for family violence. She also co-developed one of the effective prevention programs for sexual abuse, physical abuse, and bullying. She's published more than 70 papers and given over 100 presentations in national conferences. What is even more impressive is by listening to her today and spending time in preparing, really growing this entire foundation with Dr. Brown's expert consultation, and also her heart is what is most impressive. She has dedicated her career to really being able to speak for these children, to make sure that she is providing the highest quality care, to train at St. John's, and multiple people go for postdoc. Some of our own trainees have gone and continue to train. Her impact as a researcher, in many ways, she embodies the commitments and the mission to care for those who are hurting. It is my absolute pleasure to introduce Dr. Elissa Brown.
Good morning. Wow, standing room only. I don't know if I've ever had that before. Good morning. No, come sit. Join us.
This is a child grand round. Sorry.
Not at all. Everybody, of course, is welcome. Thank you so much for having me here today. It is such an honor and a privilege to be here. As as has occurred already, I really need to give a shout out to you, Erica. Thank you for inviting me. Thank you for sharing my passion and my mission. I hope I do not disappoint. So what I'm going to talk about for the next hour or so is what we know about children exposed to physical abuse and their environment, and how that informs treatment, and then in turn what we know about the treatments that exist and what our next steps need to be. The goals for today are to conceptualize the multisystemic correlates of child physical abuse, summarize the treatment outcome research, and to understand the components of best practices and how they may be implemented in the real world. As Erica started to list out, I've been extremely fortunate with funding over the last decades, and I certainly need to acknowledge, all of the agencies that have supported this work. I have to say, though, for me, this slide, don't tell my funders, but this slide is really way more important. I don't think that you do treatment outcome research, or certainly do it well, without outstanding mentorship. I know you'll recognize a lot of these names, one in particular. And I also need to acknowledge that, as most of you know, treatment outcome research it's not a lone man's endeavor by any stretch. So the collaborators that I've been lucky enough to have, including Dr. Komal Sharma Patel, who will be co-training with me over the next couple of days, and the others listed there, including, again, somebody who trained here at PI, Dr. Vanessa Rodriguez. I also think I learn as much from my trainees as I teach them. I think probably many of us feel that way. And I need to give a shout out to two who are going to kill me for doing this, but Chelsea Graff was a student with me at St. John's, and Jin Lee is a student with me now, and they are two of the most gifted clinicians that I've been lucky enough to work with. So it's wonderful to just acknowledge the mentorship, the collaborators, the trainees, and perhaps most importantly, the families who've taught me so much. All right, let's start with a basic definition. And you'd think this would be relatively simple, but it's not, because every state has its own definition of physical abuse, physical neglect, excessive corporal punishment, et cetera. I'm going to, use one defined by the American Professional Society on the Abuse of Children, which is a national organization, multidisciplinary, dedicated to abuse and neglect. Physical abuse is defined as injury to child or adolescent by a parent or other caregiver after intentional physical contact. What that means is that there needs to be injury, and that the relationship between the caregiver and the child, that caregiver has to be in a caregiving role. Physical discipline is when a caregiver uses their body or objects to punish their children. That is legal in the United States, and I'll talk about the statistics on that in a second. Physical abuse is physical discipline that goes too far and results in injury. And I could talk for the next hour about this slide alone, because I think there are a lot of cultural, philosophical issues, medical, et cetera. But I won't. All right, so now what do we know about physical discipline? 70 to 80% of parents in the United States use spanking. More than 18% of US children have had an adult injure them during discipline prior to age 18. That could be a parent, it could be another caregiver, it could be a teacher in certain states. So you gotta kind of keep a broad definition here in your mind. No gender differences here in the likelihood of being abused, although the physical injury is highest among infants, which one could understand. There's actually a surge in physical abuse around age 6. So it's really that elementary and middle school group that we want to pay attention to. When we get to older kids, we often get calls from ACS because the children have started hitting back. And so now we have this sort of iterative process of family violence. And as I think most of you know, physical abuse co-occurs with psychological abuse, neglect about 40% of the time, domestic violence about 40% of the time. So we really are talking about family violence. Although I will not be talking about international work today, I did feel the need to mention this study. There was a meta-analysis of studies done across the world on physical abuse and neglect. And the self-reported prevalence of physical abuse, averaged across all of the studies, of course, was about 23%. 23% of children across the world are reporting physical abuse. And what's interesting, and although I also study sexual abuse, somewhat frustrating to me is research really focuses much more on sexual abuse than it does on physical abuse, although the rate of sexual abuse, albeit problematic, is lower. So let's talk for a minute about the relative differences between physical abuse and sexual abuse, because I imagine many of you have worked with kids who have experienced one or both of these things. Let's start with the societal reaction. And I work in Queens, where we have families from more than 100 countries who speak close to 170 languages. This community, I think, is maybe not quite as diverse, but pretty close. And we have to really think about what children who are physically abused told about what they've been through. So the societal reaction to sexual abuse is that it's unacceptable. But for many of the kids we work with, physical discipline for sure is permissible, and what I would call physical abuse sometimes is considered to be permissible. When we think about our clinical targets, traditionally with sexual abuse, we were focused on PTSD and depression. When you're talking about physical abuse, you need to layer on what's modeled for them, which is aggression and hostility. With sexual abuse, the perpetrator is most often someone known by the family, but not someone living in the home. Whereas with physical abuse, 70 to 80% of the time, the perpetrator, which is a term I don't love, but I will use, is the primary caregiver. So the person on whom this child most depends is the one who's causing them injury. So anybody who has a developmental or an attachment perspective, just think about that for 1 sec. Oh, I'm fine, thank you. So the family dynamic that falls out of that is that in sexual abuse, you have non-offending caregivers who are distraught for sure, but often quite supportive of the child. Whereas if the person actually enacted the physical abuse and the child told somebody, there's a lot of anger at that child, not a lot of support. The safety risk in sexual abuse, the perpetrators are almost always removed from the home. No questions asked. Get that perpetrator away from that child. That's not what happens with physical abuse. And as a result, the safety risk is much higher. The target for sexual abuse treatment used to be solely the child. Now we know better. Interestingly, the target for physical abuse used to be solely the parent, and now we know better. Physical abuse almost always is chronic. Almost always. I mean, it's just in fact, I've run our clinic now with Dr. Sharma Patel for 12 years, a little longer. I cannot think of one case where there was a single incident of physical abuse. So these data, albeit old, I think just kind of support this, this idea that as time goes by, the likelihood of additional instances of physical abuse starts to go up. And everyone in the room understands that something being reported is a small percentage of the physical abuse that's actually happening. Now, the problem with this recurrence is that it affects the mental health of the kids. So interestingly, again, I think our understanding of trauma in general has grown tremendously over the last 15 years or so. We used to talk about PTSD and depression, and that was pretty much all we talked about. Now I think we have way more awareness of the variety of mental health problems that we see in trauma survivors. And this slide just summarizes what we see in physically abused kids. So when I talk to people about the work, I say our kids may have PTSD and or aggression and or depression and or social skills deficits. And I'm going to hopefully kind of use data to make this argument for you over the next half an hour or so. We have to consider all of these mental health problems, and what that means is if you've identified a child through any assessment approach as having any of these things, it's important for your case conceptualization to ask yourself why, because abuse and other forms of trauma could be a part of it. Now, the other piece is looking at this likelihood of recurrence. Not surprisingly, David Kolko, with whom I've done a lot of my work in physical abuse, been one of my really greatest collaborators, did a study years ago. We were looking at two things. We were trying to understand the mental health correlates of physical abuse, both in terms of its relationship with frequency of physical abuse, and as I'll talk about later, the way children process what happened to them. But as you can see here, very, very simply, regardless of the mental health problem, more physical abuse instances was associated with more of that mental health problem, whether it's PTSD, depression, anxiety, externalizing, et cetera, et cetera. And then what we see with other studies longitudinally is that recurrence is associated with delinquent behavior, depression, and alcohol abuse later in life. So more is bad. Now, what does that mean? That means that one of our priorities in treatment has to be the prevention of recidivism. It absolutely has to be a focus of any treatment for physical abuse. Okay, what I want to do now is start with the children and what we know about children who've been through physical abuse, and then I'm going to go to the caregivers and summarize the literature there. Some of the science was done by my team, I'm proud to say, and a lot of it's been done by others whose work I felt the need to highlight because they've done so much for the field. One such person is Seth Pollack, who's at the University of Wisconsin at Madison, and he has done incredible work looking at the neurobiology, the physiology. He does very little self-report, actually. All of his assessments are what one might say more objective assessments of abuse and its correlates. And he did an early study with Dante Cicchetti where they looked at physically abused children versus physically neglected versus non-maltreated kids and showed them faces of different emotions. And there was a clear distinction. Those physically abused kids, the fact that they differed from non-maltreated kids didn't surprise anyone, but they actually differed from the physically neglected kids in their quickness to notice what? Anger. That sort of initial, they see an angry face, boom, they're there, they've got it. And that's something that we have to think about. Again, I'm building the argument toward a treatment model. We need to be very, very sensitive to triggers, both in terms of facial expression, but also even the word anger is actually a trigger for a lot of physically abused children. These are some other studies that Seth and his colleagues have done. The first one is he looked at information processing in a selective attention paradigm. It was a more sophisticated study than the one that I just mentioned, using emotional faces as cues. And what he found is it was a replication and extension of the previous study. Physically abused children demonstrated delayed disengagement when angry faces were not informative. Right? So these were invalid cues of what was actually happening in the environment. They were inaccurate, but the physically abused kids couldn't let it go. They still kind of held on to that perception of anger. And then, of course, increased attentional benefits on valid angry trials. So lots of attention there when there's anger, but a difficulty understanding when the anger was sort of a valid interpretation of what's going on. And we see that with kids. We see that with kids in school who misunderstand how teachers talk to them, how their parents talk to them, and their reaction is to get aggressive. Why? Because they're triggered. So now they're going to go into that fight or flight response, and what fight is another word for aggression. The second study I want to mention, more recent one, Shackman and Pollack looked at physically maltreated children and found that they exhibited greater negative affect and more aggressive behavior. Okay, not really shocking. What he actually looked at, though, was the role of this sort of emotion identification and found that it mediates this relationship. So the sensitivity that physically abused children have to anger, the view of anger, the word anger, something we need to consider. All right, so affect and affect regulation and interpretation of affect, identification are things, just put that on your list. We're going to come back to that. All right, now I want to move into the cognitive realm and tell you what we know about physically abused children and their cognitive processing of what they've been through. The first thing I want to say is, what has been fascinating to me is when you get in front of a sexually abused kid and you start to do psychoed with them, and you say to them, well, how many kids are sexually abused? Most of them say, oh, nobody, just me, right? Has that been most people's experience? Those of you who I know have done this work. What's fascinating with physically abused kids is you could get that response, but then there's the other half who say, oh, everyone's hit like this. Everyone in my neighborhood is hit like this. So part of what we're doing in psychoed is really needing to challenge this view that it's only them, or that it's everyone, that it's normative, that it's acceptable. Okay. So the other thing I want to talk about is the interpretation that physically abused kids have about what they've been through. And a lot of what we talk about in my world is this issue of blame. So there was a study that I did with David years ago, looking at physical abuse versus sexual abuse. And not surprisingly, because I've laid this argument out, I think, for you now, physically abused kids are more likely to blame themselves for the abuse, or to see the blame as mixed. They're more likely to report that they deserve the abuse. And they're more likely to believe that the perpetrator didn't do it on purpose and therefore should not be punished. Now, some of what we were talking about this morning is this sort of case conceptualization framework. So you say to yourself, well, where do those beliefs come from? And clearly, the perpetrator might be reinforcing that belief system. So to me, this speaks to what we need to do with children in therapy, but also what we need to do with those caregivers. Komal Sharma Patel, who I mentioned earlier, who's my assistant director at Child Health Partnership, and some of our team, most of whom were students at the time, took this idea to the next step and said, okay, let's not just focus on self-blame, because that's important, but let's also think about the different kinds of blame. Why does blame matter? Does it matter who gets blamed? We looked at 128 youth, primarily female, all maltreated, some physically abused, some sexually abused, some both. And we did a cluster analysis to look at blame profiles. What is happening in the minds of these kids? Who do they think is responsible for what happened to them? And we have 5 distinct blame profiles. We have the low perpetrator blame, low self-blame. This is a child who's really not blaming anybody, in fact, may see the experience as accidental. We had kids who moderately blamed the perpetrator, kids who had high perpetrator blame, kids who had high self-blame, and then the combo. This group, this high perpetrator blame and high self-blame, is the one that really popped for us. Now, interestingly, because I'm here to talk about physical abuse, I wanted to let you know that we looked at whether abuse type was related to cluster, and it wasn't. So to me, I think that's a very interesting piece of the data. But what we saw here is that that last group, the high perpetrator, high self-blame group, they had the worst symptoms. So it's interesting. You might think that the high perpetrator, high self-blame group and the high self-blame group would be similar, but they're actually not. It's the kids who don't trust anyone. They don't trust themselves, and they don't trust their caregivers. Those are the kids who were off the charts on PTSD, other internalizing problems, and a number of areas of functional impairment, including just adaptability, which is so important for kids. Years ago, I was trying to develop a conceptual framework for these issues of cognitive processing and symptom picture in physically abused kids. And I really thought that there may be a relationship between the ways that somebody processes the information and the specific symptoms that they're experiencing. So we've done a couple of studies here looking at the specificity of the cognition. Is it specific to abuse, or is it a more general view of the world? And we also looked at the target of the attribution. Is it related to oneself or is it related to others? And as you can see, the attributions that were specific to abuse, which included self-blame and the perception that the world is dangerous, those attributions specifically were related to PTSD levels. The attributions, if you look at the that second column, the attributions that are related to oneself, the combination of self-blame and negative attributional style, those were related to internalizing symptoms, anxiety and depression. And the attributions that were related to others, that perception that the world is dangerous and a hostile bias, that comes from Ken Dodge's work, those were related to externalizing symptoms. So what we actually found, interestingly enough, was that the model held in 2 studies where we looked at it, that the way kids think actually may be directly related not only to the severity of symptoms, but the type of symptoms that they're experiencing. So again, I'm building this argument about what needs to be in treatment. Certainly we need a thorough assessment of affect and cognition, but we also need to recognize the importance of cognitive restructuring and other cognitive interventions in our work with physically abused kids. There's been a lot of work looking at all sorts of deficits in physically abused kids, and some of that is educational, which I'm not going to talk about today because that's just not something I know how to treat. But the social skills deficits are quite interesting. So if you think about this almost developmentally, with the younger kids, and I guess the adolescents too, we see a misreading of social cues. So a lot of this work comes from Ken Dodge and the social information processing paradigm. And Dr. Dodge has done really outstanding work here. And one of the things he talks about is a hostile bias. So I know most of you probably know what it is, but just bear with me for a sec. The way I like to explain it is if you picture 2 10-year-old boys walking down a hallway toward each other in school, and they both got their backpacks on, they're walking down the hall, and they hit each other, shoulder to shoulder, backpacks fall, backpacks open, books go flying. The first kid picks up his stuff, goes about his day. The second kid turns around and swings. Now the difference there between those 2 boys is how they interpret the interaction. The first boy interpreted it as accidental, and therefore he picked up his stuff and he went. The second boy interprets it, as intentional and hostile. And so he perceives aggression coming toward him, and therefore he's defending himself. And this is the kid, for those of you who work in schools, who's constantly getting into trouble and always tells you that it was the other person who started it, and is so upset that he's getting into trouble. He does not understand why he's getting into trouble because he sees it as he's reacting to somebody else. Well, the problem is, from an outsider's point of view, that's not what it looks like. And so this hostile bias, Ken Dodge has studied, he's a developmental psychologist, he's studied it in all kids, but what he actually has found is it's much higher among physically abused children, much higher. The other thing that we see with physically abused kids, possibly because of some of the work that Dr. Dodge talks about, is that there's lower peer status. Not as many kids want to hang out with these kids. Well, what do we know about social support and social connectedness? Where's Laura? We know how important that is, right? So now we've got kids who are sort of pinned as aggressive because of how they react when they interpret behavior as hostile, and they have trouble connecting to kids, so now they're socially isolated, which develops into having fewer social skills because, for better or worse, we all learn from our peers some of our social skills. And then sort of the last step on this social skills deficits train is that these children end up in social networks that are more insular and more negative. And an example of that is gang-related activity. So you can really see where the social skills deficits and the social cognitive processing become problematic for physically abused children. All right. I'm going to switch gears now. So now I want you guys to put your heads in the heads of the caregivers. Now, what's interesting when I say caregivers of physical abuse victim survivors is that it's not a simple, like, I'm always talking about a perpetrator. I'm not always talking about a perpetrator. Some of the time, the caregivers who are in your office or who you're trying to get into your office will be the perpetrators. They will have been substantiated or indicated, depending on what state you're in, for physical abuse, or in New York State, excessive corporal punishment, more likely. They may even acknowledge that they did it. They may not understand why it was wrong, but they're there, and and everyone agrees that this is somebody who did something they should not have done. We have another group who we often see in treatment. That's our observer, I'm calling them. This is somebody, we've had cases where the primary caregiver never did any of the hitting or any of the punishment, but certainly condoned it. And then we have, I'll call the rescuer for now, because I've done a lot of work with foster care agencies around New York City implementing AFCBT, and foster parents see themselves as the rescuer. Now, clearly, when you're trying to understand these parents, understand their histories, and engage them into treatment, each of those three categories brings its own set of challenges. And here's what's great about AFCBT. Often you're working with all of them. Yeah, everyone's like, I'm done, I'm not coming to the training tomorrow, this is too much. But it really is what makes the work so exciting, but very, very challenging. Now, when you're thinking about these caregivers, we're talking about sometimes an intergenerational transmission of violence. Now, I'm not talking about an intergenerational transmission of physical abuse to physical abuse to physical abuse. That data doesn't hold up so well. About a third of people who are physically abused will go on to physically abuse. However, a much higher percentage of our caregivers have their own trauma histories, including some form of interpersonal violence. It could be domestic violence, it could be sexual assault. And as a result, they're having that same fight or flight triggering that their kids are having. We see a variety of mental health problems in the caregivers we serve, and we have caregivers who don't have any. So really understanding that is quite important. And lastly, and I just can't say this enough, the culture and the community, and I define those terms broadly: religion, ethnicity, gender, sexual orientation, et cetera, et cetera, et cetera, all affect parenting. They affect the response to involvement of others in the family, whether it be the therapist or Child Protective Services or others. And it affects their understanding of expectations of parents in the United States, and certainly affects their belief systems about mental health. All right, let's come back to the data now. I want to start again with this affect issue. What do we know about parents who are either at risk for physical abuse or who have engaged in physical abuse regarding their affect? Not surprisingly, they're more emotionally dysregulated. There's a much lower frustration tolerance, and I'll tell you where that becomes a problem. Some of these caregivers have a misunderstanding of what's developmentally appropriate. We've all worked with families where you hear that a 5-year-old is getting a 2-year-old ready for school, and that may be culturally consistent, and it may be something that seems odd to me but works fine. The problem is when the 5-year-old doesn't do it right, do we have a caregiver who can step in an effective way, or is that frustration tolerance so low that that's going to cause family violence? Lots of negative affect, just general ambient negative affect in these caregivers who are at risk. And some studies showing us that negative affect is really mediating the relation between some personality traits and the risk for physical abuse. Now, why is that important? Why is this negative affect piece important? I think that all of us who are parents can ask ourselves, when I'm disciplining, why am I doing it? Many of us are exhausted because we try to think during discipline of what do I want my child to learn from this? And that's fantastic, although I'll say again, exhausting. But for a lot of parents, all of us probably at some time or another, the goal of parenting, it seems to be more about the release of that anger than it is discipline, which comes from the word disciple, which is about teaching. So I think when we have an elevated negative affect and the goal of parenting is release of negative affect, we get ourselves into a bad cycle here in terms of the kinds of parenting that are selected by these caregivers. And this is what makes them at risk. Does that make sense to everybody? Yeah? Okay. All right. So we've talked about affect for the caregivers, and the data are slightly different in terms of the science, how it was conducted, and yet the messages seem to be almost the same as the message I gave you about the children. Problems with identifying affect, problems with tolerating and managing affect. Now let's go to the cognitive piece and see if we have that same parallelism. One of the things that I have noticed clinically, and certainly the science holds up, is how physically abusive parents interpret their children's misbehavior. I mentioned earlier that they often have inaccurate developmental expectations of their children's behavior. But here's where it really gets problematic. They tend to view behavior that's not misbehavior as negative. They tend to attribute misbehavior as intentional. So if you're looking at this child, you know, I'm up here and the kiddo's down here, and I'm thinking, you did that on purpose to get me mad, I'm not going to engage probably in the best parenting practice that, you know, we would all like to see. So we've got viewing behavior as negative, even when it's not misbehavior. We have making attributions of a hostile intent for misbehavior. And we have this idea of having unrealistic developmental expectations and a quicker negative affect when those expectations are not met. And lastly, Sandy Azar, who is also really a phenomenal theoretrician and researcher in the area of physical abuse, has shown that the caregivers at risk for physical abuse also have poorer problem solving than parents who have not engaged in maltreatment. So you see, we have quite a mix of things that it starts to make a lot of sense in terms of why this excessive corporal punishment is happening. And it also, I think, starts to take us into a very clear path of what treatment needs to include. This won't surprise anybody. The parenting of physically abusive parents is not great. Part of it is their own history. They had limited early parenting history, like limited good parents, and few healthy models. And when they started to struggle as parents, they didn't have supportive others to help them make the adjustments. They use ineffective parenting strategies. They use more harsh discipline, more likely to use spanking. We see more impulsivity in the parental discipline. And we see a lot of intimate partner violence, which of course is creating an environment where hitting and yelling and saying horrible things is part of the family culture. Okay. So I want to sort of summarize based on what I just went through in terms of the science on kids who've been through physical abuse and caregivers who've engaged or at risk to start to pull this together as a package. So what do we know? What would we recommend for a treatment for kids? Well, we need repeated assessment of a variety of mental health outcomes and clinical correlates. We need to include psychoed about physical abuse and its symptoms to normalize how often it's actually occurring and why this aggression is such an understandable response when certain perceptions are made. And of course, to reduce children's symptoms, we want affect reg skills, cognitive therapy, social skills training, and exposure. Now, what do the caregivers need? A lot of the same things. Repeated assessment of a variety of mental health outcomes and clinical correlates, both their own and the child's. Sometimes psychoed about physical abuse, its impact. Sometimes the law about physical abuse is unknown to our families. They need a lot of engagement, and they need a lot of motivational interviewing for some of the reasons I mentioned, and some I will talk about during the training tomorrow and Friday. Affect regulation skills, cognitive therapy, and clearly parent training is a good fit for these families. There's also a family component, though. We're working in a system, and we have to be very sensitive to that system, and both in terms of the origin of the physically abusive behavior and the maintenance of that behavior. So here are some things that I think that the research argues should be included in treatment. Safety planning at the beginning and always. De-escalation work, and sometimes that's just part of what has to be done in session. Communication training among the family, clarification, which is a process that's really, I would say, unique to AFCBT. It's designed to have the caregivers acknowledge their role in the physical abuse, apologize for it, and talk about how they're going to keep that child safe going forward. Family problem solving, and of course, relapse prevention, because the family is probably living in an environment that in some way condones or supports the abuse. So what do we know about treatment for physical abuse? One of the treatments that's been studied, and the outcomes have been excellent, is parent-child interaction therapy, and I know many of you in this room know about it, and some of you have been trained in it. It was developed originally by Sheila Iberg, and it's been, I guess adapted is probably a good enough word, by Anthony Urquiza, who focuses the work on physical abuse. And he's really has an amazing understanding of a case conceptualization for how abuse begins and is maintained. So PCIT was not developed for physical abuse. It was developed for kids who have externalizing behavior problems. Mark Chaffin, with help from Anthony, took PCIT and has used it in 2 large trials in Oklahoma, throughout the state of Oklahoma, showing its efficacy with physically abusive parents, and they've had some great outcomes. Abuse-focused CBT was David Kolko's original treatment model that focused more on caregivers, as I mentioned earlier. I, through a NIH Award, developed Partners for Physical Abuse, which was an intervention for children and caregivers. Melissa Runyon, also an outstanding researcher in this area, developed CPC-CBT, which is a treatment for children and caregivers who've been through physical abuse. That's a group model. And then years ago, David and I kind of reconnected, not in terms of our relationship generally, but in working together more intensively, and combined his abuse-focused model with my partner's model, and that's what I'll be talking about over the next couple of days, Alternatives for Families, which is a cognitive behavioral intervention for family violence. Lastly, I have to mention Dr. Cindy Swenson's work, one, because she was a mentor of mine on internship, but also because those of you, I'm sure many of you know what multisystemic therapy is. She adapted it specifically for child abuse and neglect. And these are the most complicated families, most physically abused and neglected, substance abuse, et cetera, all is community-based, the work, and the outcomes have just been excellent. Now, I want to take a minute to tell you about Alternatives for Families, which is our CBT. This doesn't move, right? Is there a pointer maybe on this? Yeah. There we go. Okay. So we think of AFCBT as a 3-phase model. And phase 1 is really focused on engagement and psychoeducation, alliance building, psychoed, starting to talk about positive and negative experiences in the family, and then moving toward talking about the actual referral incident and other physically abusive situations. We also do a lot of work in that first phase with the caregiver to motivate and engage. A lot of work. We pull in motivational interviewing. We do some decisional balances about being in treatment with the caregiver. We also do a decisional balance about changing your parenting strategy, like what's the pro and the con of doing that. There's another piece that's really, I would say, unique to AFCBT, which is I'm constantly thinking about this intergenerational transmission. And years ago when I was developing my CBT manual for physical abuse, I had a team of clinicians. We were working together. And I had a clinician say to me, who do you think played with your parents, these parents that you're trying to treat, who do you think played with them when they were kids? And I looked at her, and I obviously knew where she was headed. And the answer is, for many of these parents, nobody. So there's a lot of purposeful thought in this manual about let's take care of parents before we ask them to take better care of their children. So you'll notice, I mean, a perfect example of that is that parent training doesn't start until there. Now, that used to be quite different. It used to be you get a physically abusive parent in, change that parenting right away. But I want to keep them in treatment. I want to maximize the likelihood that they actually practice the parenting skills. And so to do so, I do something with parents in AFCBT at the end of phase 1, where the parents write a letter to their parent about how they were parented. And it doesn't get sent, but it really allows them to, number one, put their mind in the body of a kid, because they're the kid in that scenario, and really think about what they were taught by their parents, good and bad, and how is that affecting how they parent today. And these caregiver letters, some of which we're going to share tomorrow, are really unbelievably powerful and build that alliance. Because the other question I always get asked is, you're an advocate. You're so passionate. You're an advocate for traumatized kids. How on earth do you work with the perpetrators? And I'll tell you that at the beginning it was hard, but I really believe that most of the time these parents are doing better than what was done to them. And these letters they write to their caregivers bring that out so powerfully. So that's phase 1. Phase 2 is really about coping, skill building, exposure for the kids, and parent training for the parents. And then phase 3 is all about family work. Everybody's coming together. The parent has worked on that clarification letter to be read to that child, but before we do any reading to anybody, this whole family needs to learn how to communicate effectively with one another. So that's a real focus there. And then that letter is read, which again, we're trying to figure out. We want to be able to play a video for you guys on Friday of a clarification session. It's an incredibly powerful moment. And then we move to family problem solving, because once you hit clarification, then it's time for termination to begin. And we want to empower that parent to be responsible for effective problem solving. All right. Now, that's all well and good, and if it works, and it does, I'm happy to say. So what do we know about the treatment outcome for AFCBT? There have been 4 randomized trials done with AFCBT. There's actually a 5th that I'm the PI on, which I'll talk about in a second. 2 of them were done specifically for physically abused kids. That was a recruitment strategy. 2 of them, the recruitment strategy was conduct and other oppositional stuff. But here's the thing. What percentage of those kids do you think had the history of physical abuse? So whichever way you go, it applies to the physically abusive families. What we find with AFCBT compared to other conditions, which are like a psychotherapy comparison condition, we see more improvement in child aggression and PTSD. Caregiver use of force and distress comes down, and the family conflict comes down, family cohesion goes up. Dr. Coco did a 1-year follow-up and found the recidivism rates for treatment as usual, which was a study where he referred to a community agency, was much, much, much higher, 33% versus only 5% for AFCBT. Our next step in the treatment outcome is looking at mediators and moderators of outcome. We really want to understand what makes someone more likely or less likely to be successful with our treatment. And it's interesting because emotional dysregulation is such an issue for our parents and our kids. And a lot of times people assume, well, if there's this emotional dysregulation, they can't do a narrative. They can't do the exposure work. They won't be able to benefit from the other parts of the treatment. And what's fascinating is Dr. Sharma Patel and I did a paper where we looked at emotion dysreg, I should say, and self-blame as moderators of PTSD and conduct problems. Meaning, does the emotion dysregulation at baseline affect the pattern of improvement over the course of treatment, from pre-treatment, if you can see, pre-treatment, mid-treatment, post-treatment? And what's interesting is that if you look here, our fear and what's talked about in the literature is high emotion dysreg won't ever respond well to this kind of treatment. It won't work. And in fact, absolutely not. And what we learn is that the high emotion dysreg really, really benefit from that second half of treatment where they do their narrative and the parents do the clarification process. Those two things have a very powerful impact on the emotion reg and on the PTSD. One last study on mediators, moderators I want to talk about. This is a recent paper that a student's working on, and she was really interested in resilience. So what she did was look at different models of resilience. Is resilience a trait? Is it something that can change over time? And the best model, the one that held up the best, is that resilience changes over time, and actually, as resilience changes, so do the mental health correlates, the mental health symptoms of trauma. So as you can, I hope you guys can sort of follow this, because what she wanted to show is that the resiliency piece comes first. Resiliency changes over time, as you can see here, from pre to mid to post. PTSD improves over time from pre to mid to post. The change in PTSD is not responsible for the change in resilience. It's actually the opposite. As resiliency improves, that leads to more decrease in PTSD, more decrease in conduct problems, more decrease in depression. So it really speaks to the value of these coping skills, because that's what's building our resiliency. All right. I want to talk a little bit about dissemination, and then I'm going to talk about next steps. As Erica mentioned, either early, at some point this morning, it's a little bit of a blur. My work in Queens is so important to me, and the work that you all are doing here with Viola Bernard is so important because we need to move into the community. We know the treatments that work. We have to get them to families who need it the most, and often those are families who will not come to a clinic that's right on Union Turnpike with a big red, St. John's red sign that says Center for Psychological Services. They will not come. And so what I tried to do with Vanessa Rodriguez and some other colleagues is developed our Project Connect, which is community networks negotiating evaluations and counseling for trauma. It's about bringing trauma-specific CBT into the community. We had a grant from the DOJ to take AFCBT and offer it up specifically to the groups that are most likely to be exposed to violence, least likely to get access to best practices. That's the African American, Caribbean, and Latino Hispanic population of Queens. And we took AF and broadened the inclusion criteria to include everything listed there: dating violence, domestic violence, physical abuse, sexual assault, and physical assault in the community as opposed to in the home. And all of our intervention, assessment and intervention work was conducted in settings that were seen by the community as safe. So we worked in libraries, we worked in churches, we worked in community centers. We did a little bit of work in schools, but not as much as you would think. And every borough is different, it seems, as to where families want to get services. And that to me is fascinating. The first thing we had to show is that the rates of trauma in our sample were the same as in our specialized trauma clinic at St. John's. And they are, you can see, tremendous trauma going on for the kids referred to Project Connect. More than a third of them had been through 3 or more different types of trauma, meaning that they could have had multiple incidents of each trauma type. And we're right in the middle now, and I'm sorry that we didn't get further on this. We're right in the middle of analyzing these data. But what we're finding is if you're looking at our preliminary outcomes for PTSD, that's the CPSS, the Child PTSD Symptom Scale, anxiety, conduct, caregiver PTSD, which was really important for us to understand, and the family environment scale conflict, we are seeing really nice improvements over time. This was a very, very small N, 20 or so. We're just beginning to look, but we have nice effect sizes showing us that these treatments, and trust me, community-based randomized trial work probably took 5 years off my life. I mean, it's unbelievably challenging, but this makes it worth it because we're having the same kind of effectiveness that we have in our clinics, and we reached families that never would have come to our clinic. So that's what that's about. The last dissemination study I want to mention is a really phenomenal enterprise taken by Dr. Kolko and his team at the University of Pittsburgh. They did an effectiveness trial for AF-CBT, and it was all about training. So they had 182 community practitioners from 10 agencies, and the clinicians were randomized to 2 different models. They either got AF-CBT training using a learning community model, which is workshops and 15 months of consultation, the way we're going to do here, versus treatment as usual. So whatever training agencies offered, that's what they got. And every clinician reported getting some training at their agency. And the clinicians did self-report measures at baseline 6, 12, and 18 months. Those who were in the AF learning community, 89% participated in at least one training activity for AF, and only 68% completed training. This was free training offered to clinicians at 10 different agencies in the community. And one of the things that we are really still struggling with is this rate of turnover in clinicians as we're trying to disseminate evidence-based practice. Dr. Kolko used an intent to train design and found a significantly greater initial improvement for those in the AF training condition in CBT-related knowledge, use of AF-CBT teaching processes, abuse-specific skills, and general psychological skills. So that sort of gives us some nice support for the work we're going to be doing over the next year together. There is much work to be done, I think, in this area. I think that we need to think a lot about training in our dissemination efforts. And as we talked about earlier, I think we need to figure out how we're going to sustain those training efforts over time, figuring out how to pay for that, but also making sure that there's that great energy to keep the training going. I think AF-CBT is a fairly comprehensive model. Not everybody needs everything. The benefit of that is the flexibility that we as developers bring to the table so that you can take a model like this and make it work for the family in front of you. But we need to study that a little bit more. I think one of the challenges with any comprehensive model, and MST is a great example of that, is you need proven cost effectiveness. So that's something I would like to see. And then I have to kind of hark on prevention for just 30 seconds, forgive me. Tertiary prevention has been, I guess that's what I'm trying to do, right? We have families who have engaged in physical abuse. We want to prevent recidivism. We need more studies for sure. The number of trials we have, I don't think is enough. Secondary prevention, I got to give credit to David Olds and his crew, looking at parents who are at risk for physical abuse and doing early work. The challenge, of course, is that they've tried to do that work with paraprofessionals who are much less expensive, and they have not had the same success. And the last thing, and the thing that I think makes the most sense economically, is primary prevention. If we can start with children, maybe middle school kids at the latest, talking about these issues of how to communicate and how to react differently if you find yourself perceiving that somebody is being aggressive toward you in communities where aggression is so commonplace, I think we could have major impacts on the psychological and economic costs of physical abuse. Thank you for your attention. I appreciate it. I'm happy to take some questions from the audience, and then I'll also be having lunch with some of the trainees, I think. Oh, any questions? Yes, there's one in the middle. You guys see?
Hi, Lisa.
Hi.
Not to put you and Eric Breschneider on the spot, but can you tell us, for some of us who are child abuse pediatricians dealing with this every day, how do we work with ACS and other agencies to get the kids to programs like yours?
Well, thank you. I mean, I think that is the question, right? So if we have primary care folks in the room, especially pediatricians who during well visits are going to see potentially injuries. Here's my first response, and I will take some responsibility, but first I'm going to kind of throw it back on you a little bit. How often are pediatricians asking about family violence going on in the home? And I know why they don't. Because once you do, you're down a really bad path of having to make phone calls and paperwork, and there's a burden, and you may lose your connection to the family. So I think that's our first step, is figuring out whatever kind of trauma we're talking about, whether we're talking about bereavement, we're talking about abuse, we're talking about witnessing violence, there needs to be sort of an annual checkup, whether it's with pediatricians who now I think have 7-minute visits. I don't know how long. I mean, it's crazy what you guys are expected to do in that period of time. We have to figure out a way to ask the questions so that we can check more often because of what I said earlier, this chronicity piece. It is such a problem that repeats itself. So that's, I think, something I feel really passionate about. How can we make it safer for children in this country? And who should be responsible for that? Who should pay for it? And then who should handle the aftermath of it? Those are very, very large questions, but things that I'm actually moving more into prevention with my work. And so I'm starting to think about that a lot. I think that once a family is identified as being in need, I think the challenge is this engagement motivation piece. So one of the some of the work that we've done at Child Help Partnership, which I didn't include in the presentation just for time, is we have taken Dr. Mary McKay's engagement work. So what Dr. McKay did, I wish I had the slides for you. I'm sorry, I can email them to Erica and she can disseminate them. What Dr. McKay has done is identified in a 20-minute scripted communication between a receptionist and a parent who's calling about mental health care for their child. She has taken that business as usual approach of, why are you calling today? What's your insurance? And she developed instead an engagement intervention that has 4 components. The first is starting with the receptionist, that BA level person having the responsibility to explain the purposes and the procedures of the mental health program. So before you ask the parent anything, you sort of say, let me explain to you how we work. Number 2, asking about why the parent's calling, but with that goal of inspiring and empowering the parent to say, wow, calling us was a really amazing next step for you. I think we're going to help you really take a different road with your child, and I can hear how much you want that to happen over the phone. Step 3 is identifying both concrete and perceptual barriers. We know that there are 2 sets of barriers that stop families from coming in. One is the concrete stuff. I need childcare, I need a ride, I need therapy where they speak Spanish, if I'm Spanish speaking. And then there's the perceptual stuff, fear of stigma, not understanding the purpose of mental health. And I worked with Mary, and we developed a script that we did at Child Help Partnership, and it transitioned families from ACS to us way more effectively. Way more families showed up, but not enough. So then I called Dr. McKay, and I said, this isn't enough. There's some stuff that's unique to working with the child maltreatment population. She said, adapt, do what you think is best. So what we added to the script is some information about how we're not ACS, because most of the parents assumed that we were, and that had some, connotations for them. Secondly, we talked about the difference between a forensic psychology clinic and a clinical clinic, excuse my language, and that was really, really important. And then the last thing is, and I think that one of the biggest barriers to treatment in the area of trauma, of course, is avoidance, right? Because most people realize if they're going to come for talk therapy, they're going to be asked to talk about the trauma, but one of the symptoms of PTSD is avoidance of anything that reminds them of the trauma. So you're kind of in a bind there. So we added that element too. So the last part of our phone script talks about why the child's going to do everything to avoid coming in. And we address that right on the phone. Step 4 is problem solving to overcome all those barriers, the concrete barriers, the conceptual barriers, and the trauma-specific barriers. As a result of all of that, we have show rates for our first visit up to 83%. And I called Dr. McKay and I said, now what do we do? And she said, you're out. You're not going to get any better. That's great. You've done great. Now maintain it. So we struggle to maintain it. We adapt the script as needed. But those pieces I think are really, really important, because these parents, and it's often the parent you're going to communicate with, right, to transition them into an effective intervention. Everybody has done this to them. Everybody has told them all the things they're doing wrong, and they assume that we as mental health professionals are going to do the same. So a lot of it is about how we talk about this. And the way I talk about AFCBT is to say, you've got a kid who's hard to raise, you've got a lot of family conflict going on, it sounds like you're pretty stressed out, everybody's yelling at everybody. Wouldn't it be great if we could just reduce the family conflict? And that goes over pretty well. Yeah. Other questions?
That was a wonderful presentation. I know Dr. Viola Bernard would be so thrilled if she would be here and hear this. I have a couple of concerns, questions really. So many of the families in our area here are not together. And there would be a mental illness in one of the members, alcoholism or drug abuse. And there are so many people who are caring for the children, other caregivers, an aunt, a cousin, a grandparent, or they would be in foster care, or where they're abused, or they would be in a shelter. And so these are the external realities that are very, very difficult once you get them in the room the way you do, whether it's in community setting or a church or a school, and there's some safety. But very often to get the person who is doing the abuse really into the room is very difficult. And I wondered how you confront this particular problem.
Yeah, I mean, I think it's very similar to the question that was asked. I think I agree with everything that you said. I think that we're often dealing with multiple caregivers with different philosophies, different approaches. I think as often as a foster parent doesn't want to be in the room because they don't think they need it, and their belief about mental health and what, that's for crazy people, that is as strong and powerful as the reasons that the biological parent who's the perpetrator doesn't want to be in the room. So I think that the first step, as both of you are highlighting, is to recognize that getting them in the room is not going to be as simple as, oh, look, I've got a 9 o'clock with, Ms. Chin today. Like, that's not how this is going to be. I think that the engagement needs to start from that receptionist who needs to be trained in how to work with aggressive parents. And it needs to go into the assessment, that intake procedure. We embed Dr. McKay's engagement strategies into our intake procedure as well. Parents need to understand why we're making them fill out all these forms, and we explain each form and the purpose of each form. We also end many of our sessions, including intake, with, tell me why you won't come in next week. Tell me why the homework won't get done. Like, I think there's a philosophy that one has to have, recognizing everything that you listed out. All of those challenges are real. That's the context in which we do the work. That isn't an adaptation. That's the context in which we do this work. So what we will do in training on AFCBT and over the consultation calls is talk a lot about different strategies for different caregivers. And the bottom line is, and I know this sounds very simplistic, but sometimes it really is as simple as, why should that person come? Ask yourself that as a clinician. Why should they come? What will they get out of coming that is meaningful to them? And what do you need to ask or assess or whatever to figure that out? Because until you have figured that out, which comes back to a case conceptualization and a good functional analysis, you're going to keep trying things that won't work. So that is the key to the work. Thank you for asking that. Yes? Oh, you have a microphone.
Hand off. Thank you for a great talk. I have a quick comment and a quick question, please. The comment is, because we're about adult and child folks in the room, is that I really want to applaud your developmental perspective. So thinking about the symptoms you're seeing in kids and what are the origins and the factors that contributed, and we need to keep that in mind when we work with our adult patients as well. This came from somewhere.
Yeah, absolutely.
The question is, you mentioned olds and the issue about training.
Yeah.
And what do you think the criteria are for the folks who are delivering the services, that you want to see delivered, and particularly your treatment? What's needed?
That is a phenomenal question. The question is, when you're talking about AFCBT or David Old's home-based approach, which is clearly a therapy approach. Dr. Olds had success with nurses, but not with paraprofessionals. We really, David Kolko and I really struggle with this. I have to say, we really struggle with it. I don't think that there's good science to help me answer the question. I will tell you that certainly there's what any clinician brings to the table, and for me, like a master's degree is enough there, but then it's the adaptability, the understanding of cognitive behavioral therapy, not as a manual, but as a framework. I mean, these families, as you say, are so complicated that, yes, of course you should plan for session and have your agenda, but you better be ready when that agenda isn't connecting. So I do think there are those other pieces that are harder to, when we send out an invitation to a training, I don't ask about creativity and problem-solving ability, but I do think that those two things are critical, and I really think a deep understanding of CBT is quite important. Some argue that a BA is enough. I don't know. I'm not quite comfortable saying that yet. But I think that's the question as we move into this Medicaid managed care system where the cost of things are, it's becoming a focus. Yeah. There's a question in the back?
Can you comment on the scenario when you've been working with a family and you're concerned or you have a clear disclosure that there's ongoing abuse and you're the mandated reporter?
Oh, sure. That happens all the time. Yeah. So, that, it's funny. I think one of the things that I forget to talk about is that because it's so integrated into our work. I think the benefit, and actually the trainees probably could speak to this even better than I could, of being in a clinic that is so trenched in trauma and thinking about being trauma informed. And one of the first things these guys learn is how to make that phone call. I have a very, very specific philosophy that I've learned from people who are smarter and way better at all of this than I am. And that is that call gets made with that caregiver. If we're 10 minutes into the intake or halfway through treatment, it's all about the alliance. It's all about full disclosure, no secrets in abuse work ever. And so we work a lot in training the staff to be as comfortable as you can be, and yet to recognize that your heart may be going 1,000 miles a minute, but you can kind of maintain that composure and do what you need to do to make that phone call. So it is an integral part of what we do, and a really important part, because many of the families know the system way better than certainly my junior doctoral students. And those families may know the system better than many of you in here. And so we're not going to pretend that that's not true. And so that's part of the discussion as well. You know what I have to do, you know why. Most of the parents are, all right, fine. They're not thrilled, but they're not shocked. And we're very clear right from the consent process about the need to call, and we remind them of that. But yeah, it's a very common issue for us. Yeah. Any other questions?
Thank you. Great talk, and a wonderfully comprehensive program. Thinking about engagement and thinking about how families that you see and families in general just have trouble sticking with protocols and treatments. I'm wondering, there aren't much data, but what essential components you would kind of flag as these are the things we really want to really focus on in treatment for those types of families? That's
a phenomenal question. So I can tell you what we've done. I've got a couple of students. One, Dr. Allison Tevitt, who helps run the AP over at LIJ, who looked at this for her dissertation, and I have a current student who's also looking at it. So I'm going to be, full disclosure, as I said, our retention rates for children we see are fantastic. We get like 75 or 80% of our kids through our entire treatment from the minute they step into our annoyingly research-oriented assessment to the end. Our retention rates for teenagers are not nearly as good, and that's something that we're really struggling with. And as a result, and for the kid piece, just as an FYI, what we found, Dr. Tebbett looked at predictors of retention versus dropout, and she found that it had nothing to do with the child's self-reported symptoms, and it had nothing to do with the caregiver's self-reported symptoms. It was the caregiver's perception of the children's psychopathology that made it more likely for them to stay in, which, makes a lot of sense. Okay. So that's why we really need to tell the parents why we're assessing what we're assessing. What we've done, and we're looking at this now to see if it helps, is we reached out to a lot of experts in adolescence and trauma, Carla Danielson and others, and we're doing very simple things to make it more likely that a New York City kid who can get from, southern Staten Island to, the North Bronx by themselves, no problem. We want to get those teenagers to come in. We're doing very simple things like having bottles of nail polish available for session, thinking what music they would want. We're doing a contingency management thing if they show up for a certain number of sessions. Sometimes we are a small nonprofit and people don't always want to give us money, but people are happy to give us toys. They're happy to give us, other kind of supplies. And so we've used those things to try to up our retention rates. And it gets back a little bit to what you were saying. We are creating this safe space. We want them to see it that way. We want them to want to be there. So that's how we're approaching it. I'll have to let you know how it goes. Well, thank you all for being here. I really appreciate it.